called Pankhudi Verma, presenter case, an unusual occurrence of angle closure glaucoma with retinitis pigmentosa.
Good morning everyone. I am going to present a case on unusual occurrence of angle closure glaucoma with retinitis pigmentosa. There is no conflict of financial interest. Prevalence of primary open angle glaucoma with RP ranges from 2 to 12%. Prevalence of PACG in RP patient over 40 years of age is found to be 1.03%. IOP elevation due to acute angle closure may aggravate the visual impairment in RP patients with pre-existing optic nerve dysfunction. Hence, angle closure related IOP elevation can be prevented by timely intervention in those susceptible eyes. So the case is a 34-year-old female presented with complaint of diminution of vision in both eyes, which was more in right than compared to left, which was insidious in onset, gradually progressive, with symptoms aggravating in dim light or at night. It was associated with headache from last 2 days, severe in nature, not decreasing even after taking oral medication, and not associated with any diurnal variation. The visual acuity in right eye was 1/60 and in left eye it was 6/9. In right eye it was improving to 3/60 and the pressure in right eye was 38 mm of mercury on gap and in left eye it was 36 mm of mercury. Cornea was clear in both eye, anterior chamber was shallow with VH1 and no AC pigmentous cells were seen. On gonioscopy, in 2-quadrant ATM was seen along with Shalvey's line in 2-quadrant with blotchy pigmentation. The pupil were mid-dilated and sluggishly reactive. Posterior subcapsular cataract was present in both eyes. On fundus examination, we could see waxy pale disc which was vertically dysmorphic and temporal crescent was present. FR was dull and severe arterial attenuation along with bony specules was present all around in the periphery. This is the gonioscopy picture showing the ATM in 2-quadrant and Shalvey's line with blotchy pigmentation. OCT RNFL picture in right eye showing RNFL thickness is outside normal limit except in the superior quadrant in right eye. In left eye, in nasal and temporal sector, it is outside normal limit. This is the single field analysis of the left eye. As in right eye, the vision was very less, we couldn't perform HFA. In left eye, it was severely depressed and glaucoma hemifield test was within outside normal limit. On ASOCT, we could see that the anterior chamber angle is shallow in both the eyes. It is 16 and 12 in right and in left eye it was 19. So the case was managed by left eye YAG PI was done and the pressure decreased to 11 mm of mercury. In right eye, the PI was done under mannitol cover as the pressure was not decreasing. In post PI also the pressure remained to be on the higher side. So then right eye phacoemulsification with PCI with trap plus MMC was planned. And the pressure came to 13 mm of mercury in right eye and in left eye it was 11 mm of mercury. The vision improved to 3/60. This is a post-op picture showing the bleb is formed, a PCL is in situ and AC is formed and surgical PI is patent. The vision I have already mentioned 3/60 and 6/9 and the pressure was again controlled. So coming to the discussion part, previous theories regarding glaucoma and RP suggested that the migration of pigment is a characteristic feature of retinitis pigmentosa and these pigments in the angle of the anterior chamber has been stressed as a possible etiological factor in glaucoma. The ultrastructure of the lens in RP is altered, causing lens fiber disorganization which may contribute to the instability of the lens with anterior displacement and narrowing of angle. Recently, zonular instability is speculated to be the cause behind angle closure in RP patient. Zong et al. Exploration using whole exome sequencing discovered that 5 genes CRB1, COL2A1, RHO, RP1L1 and PAP6 were responsible for the genetic association between early onset PACG and RP. And the predisposing factor for ECG in RP and nanophthalmos, cataract, lens subluxation, increased lens thickness, anterior segment dysgenesis and short action length. Current therapeutic strategies for PACG comprise laser, medication or surgery. So the take-home message is, tubular visual field might be observed in the patients of RP or PACG at the later stage. Therefore, atypical glaucomatous optic disc, similar visual field effect and the incidence of rarity may lead to the higher misdiagnosis rate. Hence, comprehensive ophthalmic examination including gonioscopy, full-field ERG, macular OCT and genetic testing should be done in younger RP patients in clinical diagnosis. Early intervention and maintenance of the target pressure can lead to a maintenance of the vision.